Good evening, and welcome to our Waltham Public Library program, Slavery and Its Legacy in Today's Health Disparities, with Professor Evelynn Hammonds. This is part of our series, A Year of Black History. My name is Deborah Hoffman, and I organize programs and events for the library. Thanks for tuning in. Before we start, I want to let you know how the evening will go. Our speaker will do a 40-minute presentation, and then she'll field questions. To ask questions via the chat function, use a Google account to sign into YouTube. Feel free to write your questions at any time, and then I'll read them during the Q&A. Professor Evelynn Hammonds is the chair of the Harvard University History Department. Her current work focuses on the intersection of scientific, medical, and socio-political concepts of race in the United States. And she's working on a book about the history of biological, medical, and anthropological uses of racial concepts entitled The Logic of Difference, A History of Race in Science and Medicine in the United States, 1850 to 1990. She's the author of Childhood's Deadly Scourge, The Campaign to Control Diphtheria in New York City, 1880 to 1930, and the co-author of Gender and Scientific Authority. Thank you so much for joining us tonight, Professor Hammonds.
Thank you, Deborah. It's wonderful to be here toward the now just past the end of Black History Month and into Women's History Month, so it's always a pleasure. So I'm going to share my screen for my remarks, and I'll do that right now. So what I want to talk about tonight is slavery and its legacy in today's health disparities. One of the impetuses for this presentation and the work I've been doing lately has to do is connected to the New York Times 1619 Project. And the 1619 Project, for those of you who don't know, was a major initiative from the New York Times observing the 400th anniversary of the beginning of American slavery. And its aim was to reframe the country's history and get people to understand that 1619 was one of our true founding moments, and placing the consequences of slavery and the contributions of Black Americans at the very center of the story we tell ourselves about who we are. 1619. In August 1619, an English privateer, the White Lion, entered Chesapeake Bay and anchored off of Point Comfort, a small community at the mouth of the James River. The White Lion had brought not anything, according to the records, but 20 and odd Negroes who were bought for food and supplies. So 1619, as many historians have documented, as well as in this recent incarnation, marks the inception of the most important political developments in American history, the role of democracy, and the emergence of what would in time become one of the nation's greatest challenges, the corrosive legacy of racial stereotypes and racism that continues to affect our society today. So we begin this talk, I began this talk with talking about the domestic slave trade. The slave trade in the US distributed the African-American population throughout the South in a migration that greatly surpassed in volume the Atlantic slave trade to North America. Though Congress outlawed the American slave trade in 1808, the domestic slave trade flourished, and the slave population in the United States nearly tripled over the next 50 years. The domestic trade continued into the 1860s and displaced approximately 1.2 million men, women, and children, the vast majority of whom were then born in America. By 1850, there were 3.2 million states working, slaves working in the 15 slave societies. So there was an error on my slide. And one of the issues that was very sort of prevalent and persistent is that slaves were often sold from plantations across from the upper South to the lower South. To be sold down the river was one of the most dreaded prospects of the enslaved population. Some destinations particularly in the Louisiana sugar plantations, had especially grim reputations. But it was really the destruction of family that made the slave trade so terrifying. So one way, because I have studied the history of medicine, the history of public health, when I began my studies at Harvard in the middle of the 1980s, I wanted to understand see how much information there really was available about the history of slavery and history of medicine and history of public health. When I looked at the histories of public health, one of the first things I found was one of the canonical texts was George Rosen's A History of Public Health in the United States. And his history filled an absolute vacuum. No book on the history of public health was at once so comprehensive, so accessible, and so informative. And it soon became the standard history of the subject. But in many ways, it has served to define the content and the boundaries of the field ever since. He did not address questions of race in this volume or in his other work. So when I was starting my education in the history of science, medicine, and public health at Harvard, one of the canonical texts I was looking at didn't even mention African Americans or questions of race in its story. Another important history of public health text was John Duffy's The Sanitarians, A History of American Public Health. And he noted in recent years, he stated, historians have turned their attention to the history of minorities in the United States. And the picture that have presented is scarcely a cause of self-congratulation. By and large, he noted, Americans tend to view the problems of poor minorities in the same way that they view those of poor whites, blaming their lack of good health on their way of life. On this basis, the logical assumption is that those living in poverty are responsible for their degraded way of life. If the health of Indians, Blacks, Latinos, and other minorities have received little attention in this study, he said, it simply reflects the fact that relatively little was done for them until quite recently. And for me, that is the statement of which I've been trying to understand in my work. The fact that little was done, as he notes, for these groups, Latinos, Native Americans, Blacks, and other minorities until quite recently. And is that absence of understanding why that is the case that put me into trying to understand the history, the relationship of slavery and the history of medicine and public health in the United States. So, we have to start with slavery. And so what happened to these people brought on the ship in 1619 when they became enslaved on various plantations, starting in Virginia, moving mostly to the South? The slaves suffered a variety of miserable and often fatal maladies because of the slave trade, and also because of the inhumane living and working conditions that they suffered under. Common symptoms among enslaved populations included blindness, lots of abdominal swelling due to the kind of bad food they were given, bowed legs, skin lesions, convulsions. Other common conditions included beriberi, which is a vitamin deficiency disease, pellagra, which is also a vitamin deficiency, tetany, which is also one, rickets is another one. So that speaks to the kind of diet provided to people who were enslaved on various populations. Other diseases that they suffered included lots of variations on diarrhea, dysentery, whooping cough, and respiratory diseases, which were all due to the ways in which they were not clothed properly to get through the winter months, and also where they were housed, and again, the food that they were given. Infant diseases were very, very common. And early childhood death, we already know, the death rate of children under slavery was almost twice that experienced by white infants and children. So slavery was unambiguously an unhealthy condition of life for many of the slaves. By the beginning of the Civil War, there were approximately 4 million enslaved Africans in the United States. And along with the war and the horrors that it produced, the large numbers of deaths in the American Civil War, which are still rank among the highest number of deaths of any war that Americans have participated in, the Civil War produced the largest biological crisis of the 19th century, claiming more soldiers' lives and resulting in more casualties than battle or warfare. And it wreaked havoc on the population of the slaves at the beginning and those who were newly freed during the middle of the war. It is almost impossible for us to even obtain a precise and accurate number of the freed slaves who were sick, who died due to unexpected problems caused by the exigencies of war and the massive dislocation triggered by emancipation. The Civil War, like all wars, gave rise to explosive epidemics, especially of infectious diseases, high mortality due to the inability of the newly freed African Americans to secure clothing, shelter, and food, which left many of them dead. In addition, during the war, a devastating smallpox epidemic raged across the South between 1862 and 1868, which exposed this newly vulnerable population to a disease, though it was really controlled among whites, was left largely uncontrolled among what was then the newly freed population. So we're talking about, so I want you to imagine what this was like. So in the middle of the war, you have a newly freed population. They were left plantations, but where did they go? They had no housing. They had no secure sources of food. They had no places that they could really call them their own. Many of them followed the Union Army through the final years of the Civil War. But it was really as if this was a refugee population. And I think that's the most prevalent and important metaphor to hold in your head, description of them to hold in your head so you understand what it was like. And then in the middle of this, there's a smallpox epidemic. How could they, smallpox is a highly, highly infectious disease, kills lots and lots of people. Smallpox is one of the few diseases that people feel, physicians and public health people feel, has been brought pretty much under control. If we were exposed to smallpox today, it would be a rapidly evolving pandemic. But in that point, it was also a rapidly spreading pandemic in that period as well. So here we have a newly freed population with nowhere to go, following army in time of war, and then suffering from a very serious disease. So what was the response to some of this? In this period, as we come toward the end of the 19th century, for many white Southern pro-slavery advocates, the high rates of death and disease that they saw among the newly freed population provided evidence to them that slavery was not a wholly cruel institution, because at least Black people were provided with clothing, housing, food, and work, whereas in the post-war period, it was clear to them that Blacks could not provide even a modicum of protection for themselves. And many observers, white observers, declared that Black people were just going to die out. We would have no more Black people. Some of them said by the year 2000, the entire Black population would be gone. On the other hand, the overwhelming suffering of the ex-slaves or the newly freed produced one of the first national discussions about the role of the federal government in the provision of healthcare to US citizens. Many of the first generation of African Americans who were physicians who worked among the newly freed population in the late 19th century argued to the national government that healthcare and the right to healthcare should be a right of citizenship, because the newly freed population were newly citizens, right? And so So these physicians argued, and what these newly freed people needed more than anything was good healthcare and access to good healthcare. So they were the first groups to argue for a national program of healthcare that should be provided to all citizens. This failed first federal effort because what was started at the end of the war was the Freedmen's Bureau, which was a national establishment to support and help the newly freed population to find good living conditions, to give them access to jobs, but also to provide them with health care that they had not had. But this federal effort failed. And it put the responsibility for free people's health away from, it took it away from the federal government and turned it over to the states. And of course, in the South, this responsibility was largely and cruelly abandoned. So here we're standing at the end of the 19th century. The federal government has abandoned the freed slave population, and we enter into the period of Jim Crow, where laws depriving African Americans of their rights became the norm. Between 1890 and 1894, historians have noted that the overall mortality of Blacks in Southern cities was 1.6 times that of whites. And the economic and social roots of the conditions of African Americans were simply written out of the discussion entirely. And their quote unquote inferior status had become accepted as a defining attribute of the quote unquote the Negro. And elite whites argued, well, Negroes died not because they didn't have access to healthcare, they would say, but because they were inferior. And they were classed as inferior because they died, because superior peoples were not dying under the same conditions that African Americans were living into. At least that's what these elite observers argue. So one of the first times that the newly established American Public Health Association, they had a special issue on what was happening for the quote unquote the Negroes, which is their term of art at that particular time in 1915. And you can just see from the titles of what they were looking at. There's an article on the Negro problem in Southern cities, the Negro problem in rural communities, the general Negro health problem. The Negro is a problem in public health charity, but also issues about syphilis and venereal diseases among insane Negroes. 1/3 of the articles published in this issue, which is only volume 5 of the American Journal of Public Health, were about the problems associated with the health of African Americans at that time. Something like the Negro health in Southern cities, for example, has the kind of following kinds of comments. The Negro is here for all time. He depends upon the white man for everything that makes up a civilization. These two statements being true, he is what the white man makes him. The Negro and his term covers not only the Black man, but all those of mixed white and Negro blood as well. And in this article, he said they number about 12 million. And he said it would be impossible to remove them from this country. But he depends upon the superior race for everything that makes up a civilization. And so that attitude that Black people, the descendant of the enslaved, were not fit for civilization became a very strong aspect of the approach that physicians and public health experts took in terms of thinking about whether or not they should try to help the African American population, or if this was just the natural state of the Black population to be diseased and to die off from various kinds of diseases. This discussion continued. The Negro health problem, and this author, Elsie Allen, which is a pretty particular case, said, "It is undoubtedly true that the Negro race has deteriorated physically and morally since slavery times. In some ways, he is perhaps more intelligent, but freedom has not benefited his health nor improved his morals. There is more sickness and inefficiency and crime among them than before the war. All old physicians tell us that in slavery time, consumption, which was a version of tuberculosis, was practically unknown among the Negro race. And so, but they saw that the rates of tuberculosis were increasing among African Americans in this period. And that's one of the things this author comments upon. They also commented upon the living conditions. They talked about a slowly burgeoning, emerging idea was that many white experts in the South began to realize that if they did not address issues of the health of this Black population, an impoverished population by and large, then the white population would also be in danger from the amount of disease and debility that that population suffered from. And what were they going to do about it? As one observer here says, by themselves, Negroes will not better themselves. Where they came from, they were savages. Left to themselves, they remain little better than savages. Their nature is such that benefits such as public charities provide have to be given to them, almost forced upon them. It takes much persuasion to get one into a hospital. So the dire living and health conditions that this population was under at the time was blamed upon them, right? Blamed on them for their conditions, which meant that whites were slowly at this point trying to recognize that they simply could not let Black people just die. But at the same time, African-American leaders into the early 20th century who were more educated, more professionals, more medical professionals more African-Americans were graduating from medical school. And they had the opportunity to turn and try to help the population of their own people. And one of the most important ones is from the great African-American scholar, intellectual, and social scientist and writer, W.E.B. Du Bois. Du Bois was the first African-American to earn a PhD from Harvard University. And he published in 1906, The Health and Physique of the Negro American. It was the first significant scientific approach to the health problems and biological study of the Negro. His data included information about skin color, about hair type, about morality, the Negro as patient, about migration, the effects of freedom on the physical and psychological development of the Negro. But also, he went after a lot of the studies that were coming out at the time, which were constantly comparing various aspects of Black bodies with white bodies. And these were studies that looked at almost every part of the body of Black people in comparison with those of white people. So body parts included the femur, the foot, the eye, the prostate, the spine, muscle anomalies, ear structure, skull structure, brains, skeletons, pelvises, ovaries. They looked at disease processes, fibroid processes, eye diseases, general disease peculiarities, tuberculosis, anemia, diseases of the thyroid. Every kind of disease, every kind of body part was looked at and examined between white and compared with those of whites. And what Du Bois was saying is a lot of those comparisons were biased and didn't really reflect the real conditions of Black people. And Du Bois, where white observers were willing to say that whatever kind of differences were seen between white bodies and Black bodies, they were due to race. But Du Bois asked a different question. He said, are differences in mortality rates of various diseases due to race? He argued that such differences could be explained by other factors. The high death rate of Northern Blacks was lower than both Blacks and whites in Southern cities. The death rate among whites of the stockyard districts in Chicago were higher than those of Blacks in the city. High infant mortality rates had been controlled in whites by access to better water and sanitation and infant care. And he argued that consumption, as I said, tuberculosis, was not a racial disease, but a social disease, a direct index of exploitative labor practices, poor housing conditions and sanitation, and a lack of access to medical care. And he concluded that With improved sanitary condition, improved education, and better economic opportunities, the mortality of the race may and probably will steadily decrease until it becomes normal. But Du Bois was not the only person who was concerned in the Black community. He was concerned about the health conditions, because these conditions for African Americans in the early 20th century were dire. Few hospitals, too few medical trained professionals, too few nurses, too few other facilities for the treatment and care of people. The Journal of Negro Education, published by the 1940s, a long list of statistics and commentaries that were really trying to make it clear to white elites that their assessments of these conditions were biased and were wrong and needed to be reconsidered. And so in the Journal of Negro Education, you see articles about the health status and health education of Negroes. You see articles on the problem of Negro health and vital statistics, surveys of Negro mortality, leading causes of deaths, tuberculosis, studies of other kinds of diseases, infant and maternal mortality among African Americans. And here we begin to see how this legacy is beginning to take shape. In 1900, African American women had the highest rates of maternal deaths and infant mortality. That rate has never been lower than whites from 1900 to the present day. Okay, so there's a direct link between this long period of our unwilling to address the deep problems and health statuses of African Americans and continuing problems of health disparities. But the reason I show you this is to really say that African American scholars and intellectuals began in this period to really take on these questions and really began to say, we need to do something more than simply just document them, but we need to have the kind of policies and programs that would actually change these conditions. And these scholars noted the signs of the times, however, point to a future in which the health problems of the Negroes will be thought of and dealt with as integral parts of the total problem of community, state, or national health. They will no longer be shunned aside and dealt with as separated and isolated problems that can't be addressed. And they also began to argue that the deficiencies which affected the Negro community were merely expressions in a lower key of those which influence white individuals. And it was imperative, they asked, that public health workers stop looking at this situation through these biased lens that said it was all about some fundamental race differences that caused these. But they also argued the health educator must see to it that every person, whether he be white or Black, shall be touched by the magic wand of his profession so that he may enjoy as completely as he can a state of complete physical, mental, and social well-being. Yeah, by the 1950s, Life magazine documented the still dire health conditions that African Americans experienced in the South. And there's a wonderful article in Life magazine in 1951 called The Nurse Midwife. And it's about Maud Callan, who was a nurse who did incredible work in the South in her community. She had a 16-hour day. She wasn't just simply a nurse. She was the only health provider for numbers of people in the region where she lived. She delivered babies, she took care of the sick, she administered all kinds of medicine, and she drove around and did this pretty much by herself. There she is getting out of her car with her bag, running up to meet a child who's crippled. She traveled through unbelievable conditions in rural areas to try to get help to the people that she was serving. And she held clinics in churches and buildings and backwoods shanties throughout the district where she lived. And I'm just gonna grab a little bit of my notes. In her clinic, She did not compete with the doctors. Whenever her patients are in need of treatment, Maud was in need of treatment that Maud was not, sort of licensed to give. She would take them to health department clinics in the county hospital, and she worked under one of the doctors there. And she really took on an enormous amount of work. Sorry about the slide. This is one of my slides I forgot to edit. But she was just an extraordinary, extraordinary woman. And so we're talking about one woman providing healthcare for more than 1,000 people in a rural county in the South. That's in the 1950s, still the dire state of health conditions for African Americans. And so there was a survey in the Journal of Southern Exposure, which looked at the period between the 1950s and, between World War II and the 1950s. And the report found that most of the benefits of America's health delivery system went to health providers, not to those low-income white and Black Americans who most needed help. So as long as we're going from 1900 into the 1950s and post and into the civil rights movement, where there has still been little significant change in the health status of African Americans in the American South. And one of my colleagues, Ed Beardsley, wrote a wonderful book called The History of Neglect, Healthcare for Blacks and Mill Workers in the 20th century South. And he noted the continuing health lag was apparent even in North Carolina, the state that had long been the region leader in public health programs and commitment. In 1981, the North Carolina Board of Health published an accounting of the 10 leading causes of death for whites and Blacks. And it revealed that with two exceptions, Black men and women perished at rates that were consistently and significantly higher than white rates. The persistence of such differentials in the 1980s was, as he noted, a grim reminder that too large a proportion of Black families in North Carolina and every other Southern state, quote, live outside of every legal, medical, and social advance our nation has made in this country. And we're talking about the 1980s. We're coming to the end of the 20th century. And we're still talking about this kind of really profound problems that Black communities continue to face. This is just in the American Journal of Public Health in 2019 also published an article that my colleague and I, Susan Reverby, wrote toward a historically informed analysis of racial health disparities since 1619, where we were putting to the public health community the need to pay attention to this history, as I've tried to sketch it out for you right now, of why we have been so willing to allow such fragmentation in our healthcare system, such that there are places where many individuals get the most expensive, most sophisticated, most innovative healthcare, and we still have large pockets of our population who simply do not have access to that. And without us, and so most people don't really pay attention to it, and many public health experts don't pay attention to it. And we were asking in our article for public health experts to begin to pay attention to their own history of leaving certain populations in this country without sufficient health care. I think that certainly has become evident during the time of COVID, as COVID was spreading, and you could see the disproportionate impact on various communities throughout the United States. There's no accident that rates of COVID were higher in communities where there were people lived in substandard housing. They lived in highly densely populated situations. They worked in essential jobs where they were more exposed to the virus. And most of these people also had lower insurance rates, so they couldn't get regular treatment. Many of them did not have primary care physicians. All of these kinds of structural things were evident in communities of color, and thus put them at higher risk for exposure and infection from the virus. The same communities that had higher risk and exposure to various kinds of diseases since the beginning of the 20th century. And so my hope had been that looking at this history and going deeper would help public health experts really come to terms, and physicians come to terms with this history and say, we need to do something different going forward. And that is really important, that we take these questions on. I would like to say that many of the organizations like the American Public Health Association, the American Medical Association, the National Institutes of Health are all right now vigorously engaged in coming to terms with racial health disparities. That's progress. That's important. But I hope we really do face the fact that without national health care, there are always going to be populations left behind. So thank you for your attention. I'm happy to take some questions.
Thank you so much for that outstanding talk and really important history, Professor Hammonds.
Oh, thank you. And I'm sorry, I seem to put on my screen my deck that I hadn't edited, and I did have a different one where I changed all these mistakes today. So I'm so sorry. Please forgive me for that.
Oh, well, no worries. You really told the story in a very compelling way. I have some questions for you.
Sure.
A journal of the American Medical Association podcast host claimed just last year that doctors can't be racist. So how do we affect change when medical providers never see themselves as part of the problem?
Well, you know, I was aware of those comments, and I think one of the first things to think about in terms of trying to respond to that kind of comment is that I think what people, even medical professionals, confuse is acts of personal racism versus structural racism. So you can, of course, there are many individual physicians whose goal in life and their dedication to their profession is to treating everybody the same and bringing everybody back to health at the best that they possibly can. That's different, though, than the structures that have produced the kinds of attitudes and beliefs they have about differences between Black bodies and white bodies, which is deeply embedded in medical education. And so many of them have been taught in ways that they don't realize are built upon biased assumptions. I'll give you two examples. The first one is there were recent studies that showed that African Americans are undermedicated for pain. Well, the first commentary about the fact that the idea that African Americans don't experience pain the same as whites is under slavery, where white physicians in the South talked about it all the time. That Black people, the Black slaves didn't feel pain the same way as white people. And that stayed in the medical literature for a very, very long time before it was challenged. But even in the 21st century, there are still some medical schools who teach medical students that Black people experience pain differently than white people, okay? And even my own personal experience is such that when I was in the provost's office at Harvard, I was about to undergo a medical procedure. My boss, who was also a physician, said, don't let them not give you enough painkiller. And I'm gonna call your doctor and tell them to make sure they do it. Because that belief was still prevalent and taught to him. And he had challenged it. So he understood that on a general basis, a doctor who doesn't think they're racist but knows that Black people should be getting a different amount of painkillers than white people, that it came from a racist perspective and a set of stereotypes. But that person may not know that. But my friend and my boss understood it. And he basically called the hospital and said, you make sure you give her the pain. If she says she's in pain, you make sure you're treating her pain adequately and not saying Black people don't get the same amount of painkiller. The other one that came up that I found very interesting under COVID, there were some early discussions about people who were presenting with COVID, who had a bluish color to the skin, lips and toes and other aspects of the body. And there was a wonderful piece by an African-American dermatologist who argued that when she was trained in dermatology, she was never trained to look at skin diseases on skins that were dark brown in color. So what's happening is some African-Americans presenting at various hospitals with symptoms of COVID that included the coloring of the skin. The people in the emergency rooms and when they were being admitted didn't see that because they hadn't been trained to see certain kinds of diseases on people of brown and Black skin. Again, the biases, the stereotypes are built in. So it's not a personal, so a physician is not enacting a personal animus or prejudice toward individuals. It's based on the ways they've been taught to understand that Black bodies and white bodies are different, that this is a racial difference, and that notion had not been sufficiently challenged. And that is deeply embedded in many aspects of medical and theory and practice. And so now, in order for us to get past that moment, what we have to do is reform medical education is one of the things we have to do. And many medical schools right now, the Association of American Medical Colleges is really taking that on and saying, we got to look at the curriculum. We've got to get these kinds of stereotypes out of the way we train medical students so that they actually understand that the best treatment of people of color, many people of color, Black and brown peoples, requires us to step beyond those kinds of stereotypes.
I do see some questions or comments from the audience, so I want to get to those. It seems that as long as we have a private healthcare system, these inequalities will persist, especially with the GOP's divisive, racist, self-defeating message that no one should get free stuff because then non-white people will get free stuff. So the question is, what sorts of things can be done short of switching to a public health insurance system, because that doesn't seem to be happening anytime soon?
Well, again, I think that the important thing to note, as I said earlier, is that, ultimately, I think in the US, we will simply have to reform our healthcare system and delivery of healthcare to all people. It's been a tough thing to accomplish. I'm not quite sure why, but I hope that the amount of death and needless death that we have experienced under COVID and the incredible burden of sorrow and suffering that this pandemic has brought with it will awaken people to the idea, to the notion that we could do this better. We could treat people better. We could do a better job of supporting all the aspects of healthcare and the sort of fractures in our healthcare delivery system that COVID has revealed. I think that then when we come around after we get through this, though we're not totally through it for sure, that we'll have a different conversation about our healthcare, overarching healthcare system. I think on the other hand, healthcare, I really stand with Rebecca Crumpler, who was one of the first African-American women to get a medical degree. She got it from Boston University in the 1880s. and went down south to work with the freed populations in Virginia. And she was the one who wrote to the federal government and said, healthcare should be a right of citizenship. I stand with her. It should be a right. It should be a right like voting. And we should not allow our country to deny people healthcare for any kind of reasons. So the fact that some people believe if we have federally supported healthcare, that some people are going to be getting, that some people will get it who don't deserve it, and these kinds of things. I think we can have a different kind of conversations about common good. Because if nothing else, in a pandemic of infectious disease should alert people to the fact that sometimes there's no hiding place. If we don't provide good care and protection for everybody, then nobody is safe. And so to lose that sense of our common humanity to care for each other, I hope that COVID brings that as well to light for many people who have maybe in the past had not been so clear about our connections among our different communities. An infectious disease is not going to be, if there's a high rate of something like COVID in the Boston area, in neighborhoods where there's largely poor people, that's not going to stop it from spreading to neighborhoods where there are largely rich people. The virus doesn't care. The virus is going to go find the people that are vulnerable, no matter who they are, no matter how rich they are or whatever. We are connected. And I hope that that sense of connected community is something that'll help us move forward in thinking about this, as opposed to deserving or undeserving people for good healthcare.
I know that Britain instituted their national health system immediately following World War II, because there was this feeling of we need to take care of each other after this horrible experience that we all went through, which seems very analogous to going through COVID. So that would be a wonderful time to implement that kind of healthcare system.
I think so, but we'll see. We'll see when we get through this.
Yeah. I'm sure you read about this, but recently 24 white nationalists protested outside a Boston hospital, the Brigham. And they were protesting against a pilot project aiming to eliminate racial disparities in cardiac care. Can you talk about this type of backlash in response to looking at race as a factor in healthcare inequality?
That's a good question, but it's a tough question. But I think really at the root of it is how deeply embedded the notion of racial difference is in the sort of general population in the United States, who, because of this history that I've tried to sketch out this evening, really believe that Black bodies and white bodies are fundamentally different. And it's understandable, because there's so much information that sort of moved from, medical theories and texts into just sort of what's considered sort of generally common knowledge, that people just never question some of those notions. And I think and so the problem is for people who believe that Black bodies and white bodies are fundamentally different, then it begins to be clear that, to them anyway, just as I noted in one of the slides I had in the end of the 19th century, Frederick Hoffman, who was the statistician for the Prudential Life Insurance Company, said Negroes died because they were inferior, and they were inferior because they died. And so there's this sense of Black bodies being the diseased and the debilitated and the different and the pathologically different and all of that. That says that any kind of attention to those disparities, of paying attention to something that can't be fixed because they're inherently different and diseased, and they're going to die. And so why should we be spending the money on them and not spending it on, the good white people who deserve more of our attention? It was a really, I think, shocking set of protests in front of one of the world's greatest hospitals. But it was not a surprise to me because these ideas are so readily available to be animated by people who want to preserve a particular kind of white privilege. And so it's not surprising in a moment when, as I said, medical schools, government institutions are all beginning to turn their attention seriously for the first time, I think, to redress health disparities, particularly those between whites and Blacks, and then some whites are going to feel that they're being disenfranchised. That sort of comes with the territory. It doesn't mean we have to take it seriously, and it doesn't mean that we should stop our efforts to reform medical theory and practice. It just means that not everybody's going to be happy with the choices we make to redistribute resources toward populations that have been made vulnerable and marginalized.
Another question from the audience.
Okay.
Black women are about 3 times more likely than white women to die in childbirth, regardless of income or education level, which is just tragic and shocking. Can you talk about the reasons and the remedies?
This is a really difficult problem. There was a very wonderful article in the 1619 Project book, and also in the book, and also in the original New York Times Sunday Magazine article edition by the New York Times reporter Linda Villarosa, who's been writing about this for a long time. It's complicated. And so, I mean, one of the things that it may be due to stress, it may be due to sort of the intergenerational effects of stress on generations of Black women who've lived in this country and the effects on their bodies and physiological things. It could also be continuing problems in clinical encounters. So one of the examples that Villarosa addresses in her article about this issue is she talks about Serena Williams' pregnancy and how Serena had a very difficult pregnancy. One of the most fit women in the world, but she said her pregnancy was problematic, and of course, and she's one of the richest women in the world. And one of the things that I was struck by in that part of the article is that Williams said, I kept telling my doctor that different things were happening, and he didn't listen to me. That is something that African-American women say over and over again. I go to the doctor and I try to tell them what's going on for me. They don't listen to me. And so there is something physiological happening. I think many observers begin to think about this, maybe the role of stress, maybe a number of other factors that are still not very clearly understood. But what I've read in my study of this is a consistent way in which African-American women voice the ways in which they are not heard in the medical encounter, in their clinical encounters. And I try to tell them that I'm not feeling well through this, and I don't get nobody listens to that. And even for someone like Serena Williams had that experience, that says there's something really wrong with the ways in which physicians are educated to think about the voices, the experiences of African-American women. Researchers have been trying to tease this apart and get down to some kind of causal factors, and it's still not really nailed yet. It's not really something one can straightforwardly answer. We know that these set of factors are actually producing more maternal inequities for African-American women, but it has to be shocking that we are at this point of time in advanced medical scientific research and we still can't figure this out. So I'm troubled by that. And so we don't know what the remedy is. We certainly need more and better research, but also we need a sense of urgency. This needs to stop. We need to figure this out, and we need to provide better healthcare for prenatal healthcare, postnatal care, all of that for infants. And we need to understand these maternal effects. In the Villarosa article, she also worked with, she followed a Black woman who was a doula, who helped a poor working class Black woman with her through her pregnancy. And with the support of the doula, this woman had one of her best outcomes. So support, attention, care, all of that made a difference. And that may be the thing that ultimately makes a difference. We don't know, but it's also probably diet and stress and all kinds of other things. And it's not to say that somebody like Serena Williams, though she's fit and rich, but she also was put under a lot of stress in her work as a Black woman, tennis star. She and her sister were vilified often, were put under intense media scrutiny. Those aspects of their lives are not insignificant as well. So it's a critical problem. It's one that some days I know people will work on it and feel very despairing, but there is a lot of hope because the attention to looking at the experience of women who get the kind of attention and care that they deserve, then we're beginning to see that they're having better outcomes.
Thank you. Thank you for that. I'm keeping an eye on the clock. I think we have time for one more question.
Okay.
There's a saying, where there's no data, there's no problem. How does not collecting data on race and ethnicity in healthcare settings contribute to inequity?
Well, it's good that you asked this question last. It's one of my hot buttons, because we don't know what we don't know. It is really important to keep specific data and disaggregate data that we have, not just collect data on women, but we need to look at specific women of color who live in different kinds of circumstances, experiences, have different life experiences, have different levels of access to the healthcare system, to understand what's happening to specific populations. So this is not looking at race as biology, we're looking at race as lived reality. So we need to know if there are higher rates of COVID in Roxbury, if we're talking about the Boston area where there's a large population of African Americans. But that African American population in Roxbury is not just one group. There are Haitians, there are other people from various parts of the Caribbean, there are people from the Deep South. We need to understand a lot about place, about experiences, about cultural practices, because that's what we need to understand to produce remedies that are targeted to solve the problems that these people face. If we don't collect the data that way, disaggregated by race and ethnicity, then we can't produce the kind of remedies and policies for helping them that we need. So you can't do anything about things that you don't understand and you don't know. And that's why having good data is absolutely crucial. And I'm very happy to be one of the people pushing as hard as possible for the collection of data by race and ethnicity and gender and sex and disability status and socioeconomic status as well. These are the things we need to understand, how they interact and how they affect people's lives.
Thank you. I am glad that I asked that question. Both my daughters are data scientists, so I hope that you'll be happy to hear that.
Good.
Thank you so much. I really enjoyed hosting you, and thank you for this discussion. And I want to thank you all for tuning in tonight, and I hope everyone has a good evening. Good night.
Thank you, Deborah.